We're now going to begin reviewing chapters for specific body systems and for disease processes. So in Chapter 10, we will review infectious and parasitic diseases. Chapter 1 codes take precedence over codes from other chapters for the same condition. This means that ICD9 will direct you automatically first to codes that we will be discussing here in Chapter 1. Conditions that are not considered easily transmittable or communicable are classified in the appropriate body system chapter, with an additional code being needed from category 041 to 079 to indicate the responsible organism. The primary axis for codes within this chapter is the organism responsible for the condition. Infectious diseases are classified in one of several ways. First, with a single code from Chapter 1 to indicate the organism. Some of these codes expand the fourth digit to indicate the site or the related disease process. Or with two codes combined to identify both the condition or the organism. When the main term for the condition has been located in the alphabetical index, a subterm for the organism always takes precedence over a more general term, such as acute or chronic, when both of these terms occur at the same indentation on the alphabetical index. When the organism is specified but is not indexed under the main term for that condition, you should refer to the main term infection or go to the main term for the condition. ICD9 provides 3 late effect codes for infection or parasitic infestation. When coding late effects, code first the residual, meaning the condition presently affecting the patient, followed by the appropriate late effect code, meaning the underlying condition that caused that's no longer present that caused the condition previously. Except when the alphabetical index instructs you to do elsewise. Do not code the acute infection as it's no longer present, has been resolved. TB is usually associated with a lung process, but actually TB can occur anywhere in the body. TB codes identify the specific anatomical site. The 5th digit subclassification is noted at the beginning of the section, and these codes range from 0 to 6, with 0 being used most frequently. Taking a look at the 5th digit classifications, it is important to note that they're used most often in outpatient coding, but only if it's documented within the record. So 0 means unspecified. It is not documented as to the method used to diagnose TB. 1 is when there's a specific statement in the record that no histological or bacteriological exam was done. 2, the exam was performed, but the method is unknown, meaning documented histological or bacteriological exam was performed, but the results are not within the record. And then 3, 4, 5, and 6 identify various other methods for establishing the tuberculosis diagnosis. There is a difference between active TB and a positive tuberculin skin test without an active diagnosis of TB. Code 795.51 classifies the following: a nonspecific reaction to a tuberculin skin test without active TB, a positive tuberculin skin test without active TB, or a positive PPD, or an abnormal result of Mantoux test. So it's important to read the record to see if we're dealing with a positive PPD without an active diagnosis of TB, or if there is an active diagnosis of TB. As you can see by the slide, there are many coding guidelines for the coding of septicemia, SIRS, and sepsis and septic shock. We strongly recommend that you refer to the coding guidelines whenever coding these conditions. Bacteremia is the presence of bacteria in the bloodstream, usually after trauma or a mild infection. Bacteremia is usually transient and ordinarily clears promptly through the body's own immune system, whereas septicemia is a systemic disease associated with the presence of pathological microorganisms or toxins in the blood, which can include bacteria, viruses, fungi, or other organisms. A diagnosis of septicemia can neither be assumed or ruled out on the basis of laboratory findings only. Negative or inconclusive body cultures do not necessarily mean that the patient does not have septicemia. A code for septicemia is assigned only when the physician makes a diagnosis of septicemia. The terms septicemia and sepsis are not synonymous, although they are used often interchangeably by providers. Other conditions to know are systemic inflammatory response syndrome, SIRS, which is a systemic response to infection, trauma, burns, or other insult or injury such as cancer, with symptoms including fever, tachycardia, tachypnea, and leukocytosis. You also need to know sepsis, which is a term generally used to refer to SIRS due to an infection, and severe sepsis generally refers to sepsis associated with acute organ dysfunction. The coding of these conditions require a minimum of 2 codes. Note, minimum. Septic shock generally refers to circulatory failure associated with severe sepsis and therefore represents a type of acute organ dysfunction. So coding sepsis and severe sepsis as a principal diagnosis. If it's present on admission and meets the definition of a principal diagnosis, you're going to code septic infection first, then followed by a code of 995.91, which is sepsis, or 995.92, which is severe sepsis. Also review the record to determine if there is any localized infection, as you will need to assign an additional code for that. Sepsis or severe sepsis may be present on the admission, but the diagnosis may not be confirmed until sometime after admission. If the documentation is not clear whether sepsis or severe sepsis was present on admission, you should query your physician or provider. Either the term sepsis or SIRS must be documented to assign a code from subcategory 995.9. It is important to remember that a code from this category 995.9 can never be assigned as a principal diagnosis. If sepsis or septic shock or severe sepsis develops after the encounter and was not present on admission, you're going to want to assign it as a secondary diagnosis. Again, systemic infection code is going to be assigned first, with the 995.91 or 995.92 coded as a secondary code. If the infection occurs during labor, you will code 659.3 with the appropriate 5th digit, showing the generalized infection during labor. If the infection occurs during the puerperal period, you will code 670.0, major puerperal infection. Sepsis due to a post-op infection is coded based on the provider's documentation of the relationship between the infection and the procedure. You cannot automatically assume that sepsis that is identified after a procedure is automatically post-operative complication. In the cases of post-op infection, assign first the code for the post-op infection, such as 998.59 or 674.3, which are post-op infections or post-op obstetrical surgical wounds, followed by the appropriate sepsis code, either the systemic infection code and 995.91 and 995.92. For cases of severe sepsis, assign additional codes for any acute organ dysfunction. If the post-op sepsis results in a post-operative septic shock, Code also 998.02, post-op septic shock, along with the 995.92. You should note that 998.02 can never be assigned as a principal diagnosis. In some cases, a non-infectious process, such as trauma, may lead to an infection which can result in sepsis or severe sepsis. If sepsis or severe sepsis is documented as associated with a non-infection condition, such as a burn or serious injury, and this condition meets the principal diagnosis, code the non-infectious disease first, followed by a code for the systemic infection in either 995.91 or 995.92, and any acute organ dysfunction for severe sepsis. If sepsis or severe sepsis meets the principal diagnosis, then you would code the systemic infection first, followed by the appropriate sepsis codes, and then the non-infectious condition. So again, it's really important for you to read the medical record and determine what caused or prompted the admission to the hospital. Only one SIRS code from subcategory 995.9 should be assigned for patients with sepsis or severe sepsis associated with trauma or non-infectious diseases. If a non-infectious condition leads to the infection resulting in sepsis or severe sepsis, code either 995.91 or 995.92. Do not also assign a code 995.93 or .94. If a infection is the underlying cause, assign code 995.91 or 995.92. SIRS can develop as a result of certain non-infectious disease processes, again, such as trauma, a malignant neoplasm, or pancreatitis. So when SIRS is documented with a non-infectious condition and no subsequent infection is documented, you will code first the underlying condition, followed by the appropriate code, either 995.93 or 9995.4. It's important to remember you can always query the physician if an acute organ dysfunction is documented, but it cannot be determined if the acute organ dysfunction is associated with SIRS or due to another condition. We cannot assume a correlation with dysfunction and with the systemic infectious response or with sepsis. For cases of septic shock, you will code first the systemic infection code, then the appropriate code 995.92 severe sepsis, and then a third code 785.52 septic shock. Also, a fourth code may be needed for acute organ dysfunction. For cases of post-operative septic shock, you will code 998.59 other post-operative infection before the other codes associated with the sepsis. Okay, this does not mean that the 998.59 is your principal diagnosis. Remember, your principal diagnosis is the reason for admission, so most likely the condition that the surgery was for. We have very specific coding guidelines related to the methicillin-resistant Staphylococcal aureus, also known as MRSA. So it's important that you refer to these coding guidelines. Gram-negative bacteria are a specific group of organisms with particular staining characteristics. They are clinically similar and are thought of as a group even when a specific organism cannot be determined. Occasionally, several gram-negative organisms may be seen, but no single organism is identified as a causative agent, resulting in the diagnosis of gram-negative infection. Gram-negative infections are ordinarily more severe and require more intensive care than gram-positive infections. You should never assign a code solely on the basis of a gram-stam result. The assignment is based on a physician's clinical evaluation of the condition. When the infectious organism has been identified, a specific code is often provided. When a more general code is provided, such as that for a urinary tract infection, an additional code for category 041 or 079 is assigned to indicate the responsible organism. ICD9 provides unique codes to distinguish between methicillin susceptible and methicillin resistant Staphylococcus aureus for septicemia and pneumonia. Therefore, when a combination code is available for methicillin-resistant Staphylococcus aureus, assign the appropriate code for the condition, such as methicillin-resistant pneumonia, which is 482.42. In that situation, you would not assign additional code of 041.12 because the code for the pneumonia includes the type of infection. But when there is not a combination code available, such as wound infection due to MRSA, you will need to code an additional code for a specific condition, along with the code 041.12 for the MRSA infection. Category V09 identifies infections that have become resistant to drugs commonly used to treat them. The fourth digit indicates the type of drug to which the organism has become resistant. When more than one drug is specified, assign a code for each one. The main term used to locate drug resistance is resistance. Assign only as additional codes and only when the physician specifically documents an infection that has become drug resistant. For example, resistant to penicillin goes to V09.0, or staphylococcal pneumonia resistant to penicillin and bactericin is coded to 482.40 for the pneumonia, V09.0 and V09.81 to show the two drug resistance. It's important to distinguish between colonization from infection. Colonization or carrier is when an infectious organism such as MRSA is present on or in the body without necessarily causing an illness. It is not necessarily indicative of a disease process or the cause of a specific condition, unless documented as such by the provider. A positive colonization test might be documented as MRSA screen positive or MRSA nasal swab positive. There are specific codes for carrier or suspected of carrier of infections. Methicillin susceptible Staphylococcus aureus is V02.53, methicillin resistant Staphylococcus aureus is V02.54, and we also have V02.59 for other specified bacterial diseases. When patients are in the facility with both a MRSA colonization and a MRSA infection, you would code V02.54, the code for the carrier or suspected carrier, and a code for the MRSA infection. So 2 codes are needed. We have very specific coding guidelines for HIV. Code 042 is assigned for all types of HIV infections, which may be described by the terms AIDS, acquired immune deficiency syndrome, acquired immunodeficiency syndrome, and AIDS-like syndrome, AIDS-like disease or AIDS-like illness, AIDS-related complex with the abbreviation ARC, AIDS-related condition, pre-AIDS, prodromal AIDS, and HIV disease. It's important you do not assign a code 042 when the diagnostic statement indicates that the infection is suspected, possible, or likely. So this is a very important exception to the coding guideline that directs you to assign a code for probable or possible conditions. As you're coding HIV and the related conditions, the confirmation does not require you to have the specific results documented within the record. It's sufficient for you to have the physician's diagnostic statement that the patient is HIV positive or has an HIV-related diagnosis. Coding for screening or testing for HIV is for a patient who is asymptomatic without a prior diagnosis of HIV infection or positive HIV status. Or a person who is HIV positive requests testing to determine their HIV status. So code V73.89 is used in these conditions. If the individual shows signs or symptoms or is diagnosed with an HIV-related condition, you would code those signs and symptoms or the diagnosis, and you would not code the screening condition code. When the patient makes a return visit to learn the results of the serology test, you would code, when there's negative or inconclusive, you would code V65.44, the HIV coding counseling first, and then an appropriate code 795.71 for negative. When the patient returns to learn the results of the serology test and it is positive, this means the patient has HIV, but the patient can still be asymptomatic, meaning they show no signs or symptoms of the disease. In this case, the code for the screening is not assigned, but a code V08 is assigned to show that the patient has tested positive but is asymptomatic. The patient may have also tested positive and is exhibiting signs and symptoms, and may even have an active HIV-related illness, or the physician may state that the patient has AIDS. In this case, the screening code is not assigned, but the 042 code is assigned. Once the patient has had a code 042 assigned, this is always the code used, meaning you can never use V08 again for this specific patient. When a patient has had contact with or has been exposed to the HIV virus, but shows no signs or symptoms of the illness and has not been diagnosed with a condition related to HIV, ICD9 CM provides a code for exposure or contact with HIV. The code is V01.79. Newborns with HIV-positive mothers also often test positive on ELISA and or the Western blot HIV test. This finding usually indicates that the antibody status of the mother rather than the status of the newborn, and these are coded to 795.71. Code V69.8, other problems related to a lifestyle, can be assigned as an additional code to show that the patient is known to be in a high-risk group for HIV infections. Also, code V65.44 can be assigned as an additional code when counseling is provided for patients who test positive. The sequencing of the HIV condition depends on the reason for the admission or the reason for the encounter. So, when a patient is admitted for treatment of an HIV infection or related complications, the principal diagnosis is 042. You would assign secondary codes for related conditions. When a patient is admitted to the facility for a condition unrelated to HIV, the unrelated condition is sequenced first as principal or first listed diagnosis with the additional codes 042 as a secondary code. When an obstetrical patient is identified as having an HIV infection, you would use the appropriate principal diagnosis from subcategory V647.6 for other viral diseases and code an additional code of 042. But if that obstetrical patient tests positive but has no signs or symptoms and no history of an HIV infection, you would assign a code V08 as a secondary code. The obstetrical code would be the principal diagnosis for a reason for the admission.